Good morning, Chris Ohl, Wake Forest School of Medicine, Infectious Diseases. Happy New Year. Raise your cup of coffee in the morning. So let's just get right to it. COVID in the era of Omicron and what's going on. So first thing, I'm going to give you the numbers, but people have to realize that looking at absolute case counts are becoming a little bit less meaningful these days. So the actual numbers are right now in Forsyth County we're at 164 per 100,000 per day, which is probably 4 or 5 times what it was a week and a half ago. Mecklenburg County is roughly right around 200 per 100,000 per day, and Wake is in around 300 per 100,000 per day. Why are the absolute numbers not quite as relevant? First of all, as more people become partially immune and more resistant to getting severe infections from COVID, there are a lot more colds and upper respiratory infections going around. Not everyone's going to get tested for that. 2 is you can't find a test even if you wanted one. We'll talk about that in a minute. And 3 is the home test situation, so those don't get recorded by the health department. So what do? What does Dr. Ohl do to see what's going on is I look at trends. I look at rates of peaks and rises and decreases. More increasingly, I'm looking at hospitalizations, because hospitalizations look at the tip of the iceberg. So if the entire iceberg is all of the COVID in the community, the bigger the iceberg, the more of the tip that's going to stick out, so the hospitalizations will increase. So I look at that, and that's somewhat helpful. The other thing is as we move into more of an endemic situation for Omicron, are we going to be counting numbers of COVID this time next year? Probably not. Do we count the numbers that we have of all the other cold viruses? No. We keep an eye on severe flu, and we keep an eye on percent of visits for flu to know how much flu is in the community, but we don't count flu. So we won't be counting this at some point either. That may be a little bit down the road yet, but that will be in our future. So regarding hospitalizations, right now we're running in our health system up here at about what we were at the peak of the Delta wave in the latter part of August and the first part of September. And to put it in perspective, we're probably about 30% lower than what we were this time last year for the number of people in the hospital. So what does that mean? Well, that means that Omicron is a less severe infection for the vaccinated people and for people who've been previously infected because of previously existing immunity. It still remains to see whether Omicron is a less severe virus. It probably is a little bit less severe in one sense, in that it tends to infect the upper airways, the back of the nose, the back of the throat, more than it does the lungs. And obviously infecting the lung is more of a severe thing than infecting the back of the throat. I don't think that's hard to understand. So I think that's contributing to the rate of hospitalizations being less than the rate of the number of infections in the community. For instance, at this time last year, when we had peak hospitalizations in the Triad area, our rate here in Forsyth County was about 80 to 90 per 100,000 per day. So that's a little bit of good news. What's the more sobering aspect of it, though, is for the unvaccinated and for people who are immunocompromised and thus don't respond well to vaccines, and for people who are at the extremes of age, such as over the age of 70, and who have a lot of underlying health problems. These are the people we're seeing in the hospital. And in fact, as of this morning, as of about 15 minutes ago, 92% of the people in our hospital system are unvaccinated. In the ICUs, it's even higher. Don't take what I just said to mean that our hospitals aren't busy or that we're doing fine, because we'll talk more about that in a minute. But yeah, it's tight. It's busy. There's a lot of COVID, January and February. There's a lot of other things that bring people into the hospital in respiratory infections. This is always our busiest time of year. So, if you're looking at the crush of patients, we're seeing that. And we're also dealing with reduced staffing because our healthcare workers are part of the community. A lot of people in the community have COVID colds right now, and healthcare workers can't work with a COVID cold because you can transmit it. And so that reduces our staffing. So we can keep our patients safe, but it makes it tighter, makes us busier, and that's the way it's going to be for at least a couple, 3 more weeks. People ask me, when are we going to see the holiday surge? Look around, we're seeing it. This is the people who are getting COVID now. A lot of these were exposed in and around the holidays. And I know that anecdotally. And you can't blame the school systems for transmitting COVID, because our Forsyth County schools started yesterday, so obviously not enough time. So these are kids that were exposed in with their social groups and families and sleepovers over the holidays and visiting and traveling and so on and so forth. Same thing happened last year, although the numbers of infections in our hospitals were much greater. January generally is, like I said, a tough month for respiratory infections. This is when we see our most. So we're having an intersection of Omicron during a respiratory viral season, which is not what I would have hoped for, but it's what we have to deal with. Do we still have Delta circulating? It's mostly Omicron now. I'd say probably estimating 85 to 90% of it. To tell you the truth, I think I'd rather have that than Delta in the community, if that makes any sense at all. Well, it's 2 to 3 times more infectious from person to person, and the number of people who get infected with Omicron from an exposure to a single person is higher. It is a little bit less severe for the vaccinated and previously infected people. The nursing homes in the area are starting to see outbreaks again. A lot of these are occurring from staff members. And the staff members who work in the nursing homes obviously they don't live there, so they come in and out of work. They pick it up in the community and bring it into the cloistered cocoon nursing home. So staff members have to be very vigilant about, 1, not coming to work sick, 2, participating in their testing programs that the nursing programs have, or the nursing homes have, and 3 is getting boosted, because boosting, if you've been boosted after your 2-shot series of messenger RNA vaccines or 1-shot Johnson & Johnson vaccine, you are less likely to get sick and you are less likely to transmit it to other people. So just a word about boosters still. People have to understand what boosting is. Really, boosting it's probably an unfortunate term, because what it really should be thought of, for the messenger RNA vaccines anyway, is a 3rd shot in a 3-shot series. So what we know now from how immunity wanes and with the messenger RNA vaccines, after 5 to 6 months in particular, it starts to wane, that the 3rd shot boosts that and contributes to immunologic memory so that you respond better if exposed. And so it's really kind of like a lot of other R vaccines that we use in 3-shot series, such as human papillomavirus, HPV, hepatitis B virus, the old shingles virus, and there's probably a lot of vaccines, pertussis now, whooping cough. That really should be a 3-shot series. And a lot of those already are. So Omicron's going to be that way. The ACIP has a bunch of meetings on the calendar in the next few weeks. I'm guessing that one of them is going to be a meeting to look at what we're going to call fully vaccinated. And I'm guessing that we're going to be calling 3 shots fully vaccinated rather than 2, because that's the way it probably should be. And that's what some places in Europe have already done. And I think we'll be following suit with that. So what can this 3rd shot do for you? Is this 3rd shot a complete shield that's going to protect you 100% for Omicron? No. What it's going to do is make it a lot less likely that you'll get symptomatic Omicron. Looking at all of the data put together, it takes about a 35 to 40% risk, a 35 to 40% chance of being protected, to about a 70 to 80% chance of being protected, which is a pretty good, but that still means about 30% of people might get a symptomatic infection. But when they do get infected, they get colds, and the colds don't last long, and people shed virus a lot less, longer, and that means there'll be less transmission with it. So getting the booster for a population of people will slow transmission in that population. That's the postulate, and I believe that to be true. So for certain populations of people, it really makes a lot of sense for everyone to get boosted, such as a university population, or a prison, a nursing home, places where there are a lot of people in close together. And that's why a lot of our universities are asking the students and mandating boosters for them to come back for the spring semester. It's not necessarily to protect an individual from death, because deaths in that age group are extremely rare. Not totally unseen. If you remember our Appalachian State student who still lives in our memory from a year and a half ago. But it's to slow transmission down, so that the congregate setting, like a university, can get through and complete the mission they want to do without having to do all those austere restrictions like we had to do last year, which were really tough on students, faculty, and staff. So that's why the booster mandate in those populations. Will there be a 4th shot? Well, at some point we're going to just have to stop boosting, because we can't keep boosting the entire world every 6 months. And eventually immunity will become such so that it'll be a COVID cold for everybody. So who is going to be left out are going to be the unvaccinated people. And I'll tell you, if you're unvaccinated, you will get Omicron. No ifs, ands, or buts. It's going to happen. And then the other population, our immunocompromised population. So our immunocompromised population has to deal with respiratory viruses that can be quite serious all the time. And in fact, a simple rhinovirus, which is the most common cause of the common cold, can be deadly to a severely immunocompromised patient. And it'll be the same with Omicron going forward, even though the rest of us will largely not have to worry about it any more than a cold. So what will we do for those people? Well, first of all, I think there'll be a lot more work in using monoclonal antibody cocktails. And I'm thinking ahead, and this is almost in the realm of science fiction, but maybe not that far off, is that an immunocompromised person can every 3 to 6 months get a cocktail of antibodies that protect them from most of the serious respiratory viruses. Not just Omicron, but the other ones too. The other thing is that we're having more antivirals that'll be coming out. I know right now they're really hard to get, molnupiravir and Paxlovid. We'll talk more about those in a minute. But it won't be that much further down the line, and Paxlovid in particular will be quite useful in giving to people who have compromised immune systems who get COVID. And if treated early, they're going to help them. And with maybe a little bit further data, there might be a role for it in preventing it in them too. And it'll be the same for our older people, that we would be using these much more in that population. Right now, if you're immunocompromised, besides getting boosted in the third shot, like we tell people to do, what else can you do? Well, first of all, be careful when getting together with other people. Form a cocoon for yourself of vaccinated people around you. And if you're getting together with family members or friends, you can ask them to wear a mask. Just say, I have my health issues, I would feel more comfortable. And then lastly, you can upgrade your mask. And so let's talk about masks for a minute. So there are two purposes for wearing masks during COVID. And it's no different now than it was at the beginning. One is to keep from spreading it to other people. And the other is to keep the virus from coming into your own airways to infect you. So to keep from spreading it to other people, the type of mask you wear largely doesn't matter so much. So if you're wearing a good cloth mask that's 2-ply with tight knit, so that when you breathe it goes in and out, and it fits nicely around the nose, that's going to help. That's going to keep it from giving it to other people. If you want to help protect yourself from getting virus that might be in the air, particularly when around people in close quarters, then you can upgrade your mask to a well-fitting surgical mask or an N95 or a KN95 mask. So that's largely something that's for your own personal choice what to do. And there's pluses and minuses to all of these. So let's go over what those are. The first thing is that your mask has to fit. And that means it has to fit around the nose. And it also means it has to be over your nose and mouth, hanging out below your nose so that your nose is exposed. Obviously, it's not going to work. So it has to fit and it has to be tight-fitting. For cloth masks, it's a little bit harder for that to happen. So if you put a surgical mask on top of your cloth mask, it increases the fit. It improves the fit. What is an advantage of a cloth mask? They're largely more comfortable. So if you're out and about outside all day around other people and you're wearing your mask, it's more comfortable to do so. What's the advantage of an N95 or a KN95 is it filters more particle to protect you from virus in the room. But the downside of it is it's more uncomfortable. It's harder to wear for long periods of time. So what could you do about this? Well, mix and match. If you want to protect yourself more when around other people in close areas. So let's say you're a teacher and you're teaching a class and you got a bunch of second graders in your class. Wear the N95 in class, but when you're out and about otherwise during the day, wear your cloth mask. And so you can kind of choose that. But the big thing is you got a mask. You got to wear the mask right, and it's got to be fitting. So anyway, a little bit of an aside from the immunocompromised host, but I think immunocompromised hosts should be wearing an N95 when they're out around other people. So what's going on with testing? Well, we don't have enough of them, and I don't think that's a surprise to anybody. And some of this is our own fault, because in December we were telling everyone to get a test before they traveled, after they traveled, before going to the basketball game, after, and so on and so forth. So a lot of people are doing that. The problem came in is that the home tests are pretty much exhausted. I think it's hard to find them right now. And because the home tests are exhausted and people still want to get themselves tested even though they're fine, they're going to healthcare places to get tested. They're going to urgent cares, they're going to emergency departments, and they're going to their physician's offices. And I wish we had enough capacity in those areas to test people who just want to test so that they feel better and that they're reassured. But right now it's a 3 to 4 hour wait in an urgent care. And if you're there for another reason that really is urgent, that is a problem for those people, particularly in the emergency department. Emergency departments are for emergencies. And if there's a lot of people who are there just simply to get a COVID test, and that's really the reason why they're there, it really gets in the way of taking care of people with real emergencies. That's a problem. And so we have to protect our emergency rooms to be able to do their mission of taking care of people who really need an emergency. So I understand that some people don't know for sure whether their cold and flu symptoms are an emergency or not. So here's the thing. If this is a cold or flu type symptom like you normally have, when you get a cold or flu, you don't need to go to an emergency room. So if you have a fever and some aches and a bit of a sore throat, Omicron isn't any more of a horrible devil than any other virus in that situation. So you look at your symptoms. You don't necessarily need to run to an emergency room for a test. But if you're short of breath, and the times where you get short of breath, you'll notice that it's like when going upstairs from the basement to the first floor, from the first floor to the second floor. If you get winded and you can't, and normally you have no trouble and you can't catch your breath, that's a reason to go. If you have problems cognating, so you can't think, or the people around you think you're not thinking clearly. If you have a pulse ox at home, and a lot of people have those, if it drops down below 90%, then that's a reason to go to an emergency room. So save the trips for the emergency room. One other thing that I want to mention is our EMS. What's EMS? That's our fancy initials for the ambulances, for the that come and they're really swamped right now. And if they get any more swamped, it's going to start impacting on call times, which means that a person who gets hit by a car out on Robin Head Road in Peacehaven, the ambulance may not show up as fast as it normally would. And so please do not call an ambulance unless you're really having an emergency. If you can't breathe, if you're having a lot of chest pain, or if something like that, that's different. But if it's simply so you can go get a test, that's abusing the system, and it's going to take away our ambulances for people who really need them. So I wish I didn't have to say that, but that's the case. So if you need a test, what do you do? Well, first of all, what I would say is that if you have symptoms right now of a respiratory tract infection, sore throat, stuffy nose, a bit of a cough, and maybe a plus or minus a headache, plus or minus a fever, and yeah, if you can get a test, it's worth testing yourself if you have symptoms, because not all of these are going to be Omicron. And so the isolation and quarantine time is a little different from Omicron than it is for the other things. So that would be a reason to get tested. But if you really aren't going to be out and about, or if you're not, needing to go to work, or you can call in and not go to work for 5 days with your cold or flu, this is Dr. Ohl talking. It's probably okay to not get tested right now. When we talk about quarantine and isolation, you'll kind of see how this all comes together. So the people who really, really need to get tested, healthcare workers, we need to know whether you have Omicron, we need to know whether you have COVID or not, because that impacts how and where you work and how long you are out for work. So those people need to get tested. People in essential jobs, firemen, policemen, people who work in grocery stores, so on and so forth, those people, we need to get tested. But if people who have considerations with their families, people who are around immunocompromised people, that's different. But does everyone absolutely have to have a test if they have cold or flu symptoms? Maybe not. So you can assess your own personal needs and the needs of your workplace and the needs of your family, and go from there. So what about the isolation guidance? This is, the CDC's isolation guidance. Poor CDC is getting beaten up, no matter what they do on this. So let me try to give you a little bit of insight on the background of this. So when and how and why do we isolate? So what we want to do is isolate people who are at risk of spreading infection, who are infected. So one of the things about the SARS-CoV-2 virus and COVID is that not everyone has symptoms with it. And so, and if those people get tested because they're exposed or for some other reason and they're positive, that's one group of people. The other thing is that how long do you really shed these respiratory viruses when you get infected? So we have some pretty good information now, and even with Omicron, that the vast majority of viral shedding is over by day 5. Probably somewhere around 85 to 90% of people are really not shedding viruses in the infectious range anymore around day 5. Now, this is, if you look at it, for those of you who've got some statistics, it's a bell curve, right? So it's 85 to 90%. So you're looking at standard deviations and a little bit of math to figure that out. But for one individual, sometimes you don't quite know whether they're in that 10% or not. So the thing is that having a 10-day isolation period when there are so many people getting COVID is quite disruptive. So if everyone in the meat department doesn't come to work because they're in 10 days of isolation, it means there's going to be no meat in the counter. Your FedEx package won't show up. So on and so forth. For healthcare workers, we can't get people back to work to take care of sick people. So the CDC has to balance all that. And so what they do, this is public health, and what we do in public health is we look at standard curves and we look at the majority of people. So what they're saying is 90% of the time, if viral shedding is not at the level that that is transmissible, that's pretty good. We'll take 90%. And when there is so much COVID out there, if you have somebody come back in that 10% window, anyway, it's like throwing a thimble of water into the ocean, right? Because there's COVID everywhere. So bringing somebody back a little bit early isn't quite the impact. The other thing is that they got into that. Well, a lot of people, particularly epidemiologists, not so much the infectious disease doctors, because we think a little bit differently, said, well, at day 5, why don't we just test them to bring them back, test everyone? Well, one, we just told you, there aren't tests out there. So if you don't have them, it's really hard to do that. 2 is what does the test measure? So a PCR measures the RNA in the virus. An antigen test measures pieces of the protein coat that are around it, the spike protein. If you have a person who's infected, and on day 5 or so you do a test, it could be positive because it's picking up what I call COVID carcasses. So non-viable virus, they can't really transmit that easily anymore. But if there's still pieces of it hanging out in the airways, the test might pick that up. So you could get a positive test and not be able to transmit it. You could have a negative test, and it doesn't totally rule out that you might have a small possibility of transmitting it. So the test isn't quite as helpful as you think. So for us in infectious diseases, we think about this stuff all the time when we do infectious diseases testing. But I think people at large think of a test as being positive and negative, and as it being the end all for everything all the time. So that's when they were speaking about the test maybe not being as helpful as you would like it to be at day 5, that's what they were talking about. And it's a hard concept for people to understand, and it seems to have been very hard for the media to figure out. But that's the way it is. Do we have a test that can actually measure how infectious you are? Not really. No, we don't. The best way to do that would be to measure viable virus, to collect specimens and then grow the virus. If you can grow it, then there's a chance you're infectious. But labs can't do that unless you're a very highly specialized research lab. There is a somewhat of a surrogate looking at what we call, for the PCR test, looking at cycle times, which is how long it takes for the PCR to become positive. And even that's not 100%. But if it takes a long time, generally there's less virus around. But it still doesn't complete measure infectiousness. So that's the thing about the CDC things. So it seems like we're kind of split in the world of epidemiology, public health, and infectious disease. There's still a camp of people who think we should be testing to bring people back after they've had COVID at day 5. And then there's the camp that says, nah, we probably don't need to, just let them come back at day 5. You know, the answer, like most things, might be a little bit in the middle. So let's go through a few examples. Let's say you are a healthcare worker and you're going to work in the bone marrow transplant unit around other patients. You might want to have that extra degree, that slight 10% extra degree of certainty that you're not infectious. The best way to do that, the only way to do that, is to do a test around day 5 to 7. And so for that group of people, healthcare workers, yeah, it's probably worth doing, I think. People who work in nursing homes, it's probably worth doing because the stakes are so high. For students in a college going back to a roommate in a dorm room, a 12 by 12 foot cubicle, which is called a transmission room in our world, because it's a very high risk of getting it. Think about your college days, how many things the roommates share in those rooms. That's probably worthwhile doing a test to come back off isolation. It probably also makes a sense whether you've been vaccinated or boosted versus unvaccinated, or just vaccinated without a booster, and we're trying to sort that out a little bit now. But vaccinated and booster people, maybe it's not as important to have a test to bring them back as it is with unvaccinated people. And so, have we heard the end of isolation and quarantine advice? Probably not. As we get more data and time evolves, it'll change. And as the stakes change, it'll be. I think we'll probably see some updated guidance as time goes on, and that's okay. It doesn't mean that the CDC doesn't know what they're doing. It just means we're adjusting to how things are interpreted. The other thing is that after the 5 days, if you're wearing a mask and the mask is well-fitting and you're very good about how you wear it, that's going to take care of, I think, that 10% of people who might still have a risk of transmission when they come back. And so largely I agree with their guidance. I might get beat up by some people for saying that, and that's okay. But I think that's probably the way to do it. Lastly, about treatments, we talked some about this last week. Monoclonal antibodies, there's only one that works against Omicron. So I had to chuckle when the governor of Florida said that he wanted to open up monoclonal antibody treatment centers all over rather than giving people vaccine boosters. I don't know if anyone told him that the monoclonal antibodies don't work for Omicron, except for one of them, and that's in such short supply right now you can't. It's really hard to find and get, and we're pretty much limiting that for severely immunocompromised people because they need it. They really need it to stay off a ventilator. The antiviral drugs, molnupiravir and Paxlovid, once Paxlovid supply starts to increase, I think you'll see molnupiravir go by the wayside. It's just not that good of an antiviral drug, in my estimation, and when I look at the data. And there's also some issues about pregnancy, and you have to be on contraception and such to take that drug. Paxlovid, once it comes up, will be the one that we'll be using. And then there are a few others that are in the pipeline, I think, that'll get approved that look promising early on. So the problem with Paxlovid right now is that, that it's going to take a while to distribute it and get it out across the country. So how are we doing it? Well, it's not like any other drug where CVS buys it from a distributor and then can get it. So these things are being distributed through our governmental public health systems. And so we get our Paxlovid from the state. The state distributes it. Frankly, we're rationing it because there's just not enough to go around. Right now, just like with sotorasib, the monoclonal that works for Omicron, we're reserving it mostly for immunocompromised people because it just simply doesn't make sense to give it to a person with a cold who's going to get better in 2 to 3 days anyway, when you could keep a person with leukemia off a ventilator. And so that's who we're giving it to right now. So be patient. I think it'll ramp up fairly quickly, just like vaccines ramped up pretty quickly last spring. And I think by the time we start to see spring come around, you'll see a lot more treatment. And you'll probably be able to get a script at your doctor's office then. But right now we have to ration it to get it to the people who really need it. So that's all I have for this morning. Any questions from the group?
Yes, someone asked that if they're taking a flight and like getting on a flight and then they want to test after taking the flight, what day after should they take a PCR?
Yeah, so if you're, first of all, right now, I'm not so sure that it makes a lot of sense to be doing this because testing is in such short supply, and personally I'd rather see symptomatic people getting it. But let's say you're in a situation where it's really important. You got an immunocompromised person in your house, or you're taking care of grandma, or things like that. So I understand that there's people who are still going to need it. First of all, schedule that test well in advance. So if you know you're going somewhere, schedule that PCR well in advance, because it's like a 1 to 2 week wait sometimes for this asymptomatic testing. Second of all, you may not get the result right away. So if your result is delayed, then wear a mask and be pretty religious about it after coming back. What day should you get tested? Probably sometime around day 3, I think. Omicron seems to have a little shorter incubation period, so, that's what I'd recommend. You know, I know a lot of international travelers right now are having a devil of a time getting their required tests to go. Fortunately, some places are starting to back off, like the UK just backed off the needs for being tested before coming, because the UK has got more COVID than anyone else around. Speaking of which, by the way, if you're a follower of curves, follow the UK right now, and follow their curves, and you can get this. Best place probably New York Times website, and you know, it's plateauing. Their Omicron burst, I think, is starting to plateau. Check back with me in 3 or 4 days, and we'll see if it continues that trend. But that's good news, because they've been in their burst for about 2 to 3 weeks. And if they follow South Africa, that means in another week or 2, they'll be in a comfort zone. So that would be what portends what I think might happen with our curve here. If you look at Denmark, now Denmark did a couple things. First of all, they have all Omicron too, but they put in a lot of restrictions, kind of like a lockdown kind of thing, which is going to flatten their curve, but it's also going to lengthen it. Here in the United States, I don't think our curve's going to be a long one. And if you look at the UK data, don't quite hold me to it yet, but there's a little bit of hope in the back of my head now that by the time we get in and out of January, a lot of our Omicron problems will be starting to get much better.
So with that, you talk about it becoming kind of an endemic, right? And that we may see Omicron for, you know, still talking about it next year. Is that something likely, or is it going to be a new variant then? I mean,
yeah. Well, I'm going to stop predicting about new variants coming around. You know, there really are only so many mutations this virus can throw at us. The thing is that if you look about the history of pandemics forever, the pandemics are most explosive early on, and then each time they come through with a wave, it's less so. And the virus tends to get less mean as time goes on. Maybe the number of infections doesn't change much, but they become less meaningful. So will we be talking about Omicron this time next year? Not as much as we are now, no. Will it still be here? Sure. You know, it's whatever virus has the most transmission fitness will be the one that takes over within a class. So if another variant comes around that has more transmission fitness, it might take over from Omicron. But more likely than not, it won't be, you know, any more severe as Omicron, which is, like I said, as the population becomes more and more immune, becomes less and less of an issue. So, you know, it's kind of funny. Think about your last cold that you had. Prior to COVID, just make it simple. The last cold you had, did you talk about what virus it is? Did you talk about, you know, call your buddy up and say, hey, I have to cancel the game tonight because I have rhinovirus 76213. No, I have a cold, is what you say. So that's what people will be saying as time goes on. Yeah. We're in a transition period now, which is a little awkward, but yeah, that's what it's going to be in the long run.
So we've got a question that came in. Apparently there's some restaurants that are closing temporarily. What your thoughts on if it's safe for restaurants to operate, and how can restaurants operate safely during this time?
Okay, so how can restaurants operate safely during this time? So there's a few issues. Some of the restaurants closing is not for safety. It's because they can't get the wait staff and the cooks because they have COVID and they're sitting out there 5 days at home. And so a lot of it's staffing. And I mean, restaurants, if you remember, even last summer, during the, quote, good times before Delta, I mean, restaurants were having staffing. They were struggling with staffing even then. And so it's tough for them to stay staffed when their people are getting sick. As far as going to a restaurant safe, the thing about restaurants, obviously, is when you're dining, the mask comes down. And when the mask comes down, then the risk of transmission from person to person, particularly with Omicron, is going to go up. So now, if you are healthy and you're not at an extreme of age and you've had your 2 shots and a booster and you really think you need to go get that dinner right now, if you want to take the risk, if you get it, you're probably going to get a cold. And it'll put you out of work for 5 days or out of school. Or are you going to say, hey, I'd rather just, maybe I'll wait until February, Valentine's Day. Let's make the reservations for that now. And I personally probably would do that. And I know our restaurants don't want to hear that, at least the ones that can stay open. Now, if there's a way to do outdoor dining in big areas, it reduces the risk some. But I know for a lot of places that do catered dinners and or have food with meetings, which is very popular in workplaces. Come to this meeting, I'll reduce the pain by feeding you lunch of having to sit in the meeting. Those right now, I think that's probably not a good idea. And if you have to serve food at an event, take it outside, put it under the patio heaters, and then when you come back inside, mask up.
I know you hit on it a little bit earlier, but several questions about the mask and the different type of mask. So you're saying people that just have a cloth face mask should still feel fairly safe as long as...
Well, I'm still wearing my cloth face mask. But, I'm... when I go... excuse me. When I go into the hospital and I'm, around a lot of people, I'm either wearing an N95 or a surgical mask, kind of depending on the situation. So I make my own decisions on that. But, if I go to the grocery store, I wear a cloth mask. But, I have a quilted 2-ply tight knit. It fits well. I'm in a mask almost 100% of the time of the day. So I'm not sure I could do an N95 that long. But so you have to kind of make your own personal decisions on that. But if you have health problems or you're older or you're immunocompromised, put the N95 on because it's about protecting you. This doesn't change much dispersion because the droplets, particularly I think with Omicron, that come out of the upper airways, when they first come out are going to be the larger ones and the ones that are going to get caught up in the mask. And they'll reduce the number that come through enough, I think. I mean, the CDC said this week, too, that for most things, cloth masks are still going to be okay. But, if you want to wear an N95, that's fine. I'm not going to beat you up for it. And if you want that extra degree of protection for yourself, that's great. Go for it. We're not really in a situation of short supply like we were at the beginning. So it's not like we're trying to reserve them because we have enough. All right. We'll see you next Thursday.